Good evening. This is Dr. John Bennett. Today we have uh, the good fortune of having Aneela Darbar, excuse me, MD. She's a neurosurgeon that from Pakistan originally. She worked in St. Louis and now she's back in Pakistan. She's going to talk about endoscopic skull base approaches. And also we have a very distinguished member of the panel, Victor Hugo Perez, who did a fantastic impromptu discussion today of neuroanatomy. First, we'll greet Victor. Hi, Victor.
Hi, how are you?
How you going, Victor? Can you talk a little bit about yourself, please?
Yeah, it's very nice to know you, and yeah, of course, Mexico City. So I have been
Where do you practice, Victor? Where do you practice?
my practice is in Centro Médico Nacional. I am a skull-based surgeon and also a surgeon. I did a research fellowship in Detroit, Michigan about 23 years ago. So right now I am doing a skull-based surgery and also research in anatomy, surgical anatomy of the brain, skull base, and also the spine.
Very good. Welcome, Victor. Okay, Aneela, it's your show.
All right, so let me just start this. I'm going to minimize this first.
Okay, can you just say a few words about yourself, Aneela, where you went to school?
Sure.
Residency?
I am Aneela Darbar, and I did my neurosurgical residency from State University of New York at Syracuse. And then I did my first fellowship in the endoscopic surgery with Dr. Charlie Teo in Sydney, Australia. And then I joined the St. Louis University. I did my second fellowship with Dr. Salim Abdul-Rauf in vascular and skull base surgery. And then I was a faculty there for 3 years. And then I moved to Pakistan, which is my home country now. And I practice in a university called the Aga Khan University in Karachi.
Very good.
Okay. So I'm just going to start now.
Oh, sure.
First, I have to open this.
Okay.
I am not seeing the button here at the edge of the task. In the task bar, I am unable to see. I've opened my PowerPoint.
Okay. Okay. Go to the taskbar and open the Hangout again. Click on the Hangout again. Come back into the Hangout and go to the menu on the left side. Click on Screen Share. You got that?
Yeah, I got that. I did the screen share now.
Now, does it open up and show you a couple of options on what to pick?
Both the options are, one is the Hangout and the other one is the entire screen.
Okay. First, exit the Hangout by the right-hand corner. There's a minimize button. Exit the Hangout.
Did.
Okay. Now you got your screen, your desktop in front of you. Open up the PowerPoint.
Correct.
Open up the PowerPoint and leave it there.
Okay, I did it.
Okay, then now go to the taskbar and open the Hangout again. Okay, did you open the taskbar at the bottom?
Yes, yeah,
okay, now
I did it.
Go to the menu on the left. Go to the screen. Click the screen share button.
Okay.
Now another screen should open giving you options. Your screen share should be there.
Yeah, do you see it?
Yeah. Yes.
Okay.
Okay, click on the appropriate place to slide or whatever.
Yeah, so this is the first slide. Can you see the endoscopic skull base approaches?
Yes, you gotta click on the slide, I believe, to start it.
Is it working? Do you see it?
No, we're seeing a bunch of slides. We're not seeing the one slide. You want to show one slide, right?
Yeah, yeah. I have a, okay. So why is this happening?
There you go. Now click on each individual slide. There you go. Okay, there you got it. And now when you change slides, you have to go to the left column and click one by one.
Oh, okay. So I just can't run the slideshow.
Yeah,
Okay, I got
exactly.
it.
Okay. Okay, you're off.
Okay,
You're off.
I'm on. Okay. So I will be talking about the endoscopic skull base approaches. And this picture just shares what is the current status of the skull base surgery. And we can access the most common use of the endoscopic surgery. Most of the neurosurgeons around the world use it for accessing the Sellar, and most of the transsphenoidal surgery these days are actually done endoscopically. But along with the Sellar, you can also access via the endoscope the anterior skull base, and also you can access it the posterior skull base all the way up to the clivus. The advantages of using the endoscopic skull base is that it has more rapid access, it gives you brighter illumination and visualization, it gives you greater magnification, a wider field of view, and then you can directly inspect the tumor bed. The other advantages are that you do not require any kind of nasal packing or nasal splints as when you use in microscope. There is also less post-operative discomfort, and also eliminates most of the other ENT complications that used to have in the older kind of procedure, which was done before the endoscopic procedure had gone into vogue. There is definitely better degree of tumor resection, especially now. There are safer surgical corridors that you can use. There are lesser complications and definitely much more shorter recovery stay. Now, the advantages of endoscopic approach versus all the other approaches is that rapid access, the neurovascular hurdles doesn't come in your way, except if you are going into the anterior skull base or a little bit in the posterior skull base. It may or it may not, depending. The access to the midline tumors are great. Paramedian tumors, you have to think how much is the lateral access. If there is too much lateral access that you won't be able to do it endoscopically, some lateral access can be approached, but extremely lateral tumors, as I will show in my further slides, cannot be accessed through endoscopic surgery. You cannot do an en bloc resection, and the cosmesis is great because there are no cuts. It's all done through the nasal approach. Disadvantages: there are two-dimensional vision. Although there is a scope out there made by the Vision Sense these days, which gives you a 3D view, and you can wear one of those 3D goggles and have a view, and it gives you a good 3D approach. But in my experience of using that camera, I have found that the resolution is not fantastic, although the 3D approach is really good and the depth perception is good, but in my experience, the resolution is not good. So I still use the traditional high-resolution camera with the high-resolution HD camera with the screen, which is usually made by any other company. I use Stores, but there are many other companies that make it. One of the other disadvantages is that a limited surgical corridor. Now, people who don't use endoscopes have a bigger view of the fogging and obscuration of the endoscope with blood, and it is a steep learning curve for you to understand how to get rid of it. I usually use a sheet with my endoscope with a direct irrigation that with a foot pedal. So whenever there is fogging or obscuring, I don't have to take my endoscope out. I just push the pedal and it irrigates my scope, and as a result of which my vision gets cleared, and that's why there is no delay in the surgical time by coming in and getting off. These things are very commonly available with any of the endoscopes if you go out in market and search for it. People who don't use endoscope, for them it's an unfamiliar anatomy, and that needs to be learned before going through it. And although in older days it was a one-handed surgeon technique, but now currently we use a four-handed surgeon technique actually. So we use both the nares, and through one nare the surgeon holds two instruments, and the assistant actually holds one suction and endoscope. As a result of which, it is now a four-handed surgery, so much more easier, and as a result of it, you can take bigger tumors out, anterior skull-based tumors out, because they are four hands, just like if you're doing a regular surgery. The limitations are usually by location. So if your tumor is a lot into the cavernous sinus, especially if you're doing a sellar or a suprasellar lesion, then if you are, there's a lot of cavernous sinus extension, then you are limited by taking the entire tumor off, in spite of using different degree scopes. And the other problem is that you cannot go caudal to C2, because no matter, even if you do a 70-degree scope, you won't be able to see so posterior inferiorly. Vascular tumors are very difficult to take out, and again the reason is because it fogs the scope so much that even a little bit of blood looks like a whole lot of blood when you're looking into the screen. And tumors that require en-bloc resection cannot be done through endoscope. There are some specific contraindications, like craniopharyngioma that has been resected several times before. Like a first-time craniopharyngioma in the sellar and suprasellar can be accessed through endoscope, but if it is a redo procedure, then you have to be very careful, because sometimes these tumors are stuck to big vessels, they're stuck to carotids, they're stuck to the basilar. Sometimes the bone, the dorsum sella is actually not there because the tumor has eroded through it. So you have to be very careful in doing a redo craniopharyngioma or a redo meningioma through the endoscope. You just have to be very careful, maybe have your neuronavigation with you so that you can see where you are, or maybe do an open procedure in case you feel that the tumor would be stuck to the vessel. So for the anterior cranial fossa approach, anteriorly you usually have no limits. Laterally you have the optic nerves as seen over here, and that usually would limit you. And posteriorly there is no limit because you enter into the tuberculum sella and the sellar region then. So from here to here you can do a transplanum, transtuberculum, transcribriform approach. It's great for idiopathic as well as traumatic CSF leaks. You can easily put your scope, find usually most of the leaks are through the cribriform plate. You can find the leak and then seal it. Of course, there are several ways of sealing it, which I'll divulge into it as my presentation goes on. It's rapid and relatively risk-free, and again, you're laterally bounded by the optic nerves and posteriorly by the circular sinus. But anything in this area, like for example, a tuberculum sellar meningioma is very easily accessible. If you even have an olfactory groove, that is also quite accessible through here, because the only thing you have to do here is actually just remove these bones and you would be just directly accessing the tumor. I usually use my ENT surgeon, who actually helps me drill the bone. Even for this, in all approaches, anterior, sellar, posterior approaches, I use the ENT surgeon to do this approach, and then I go and do the tumor bit after. This is just some of the example of endonasal removal of the tumors. Unfortunately, my slideshow would have shown, because this is an animated picture, the slideshow would have seen the post-operative picture, but unfortunately I can't now in this case. John, if I put into the slideshow, it won't come, right? Okay. So again, this is you can, as I told you, can take olfactory groove, tumors out, you can take the tuberculum sellar, and this is just a post-op picture of the pre-op picture that was shown right here. Okay. So when you do tumors like these, of course, there is, you have removed a bunch of bone, you have opened the dura, there's a huge CSF leak, right? And these are not the kind of CSF leak that can be just sealed with a fat graft or artificial dura or any other material, because they are big CSF leaks. They are not smaller CSF leaks like the one we have in the Sellar approaches. So for this, you need a vascularized septal flap. This is the vessels that supply this vascular flap. It's the inner mucosa. This is called a Hadad flap by an ENT surgeon called Hadad, and basically it starts from where when your sphenoid ostium is, that starts from there. Then you go all the way up, and then the other part is actually into the nasopharynx, and then you join it together to raise a flap. The flap actually looks like that. This is just, I've just taken it out to show it like that, but it is attached. The flap is attached over here, and the blood supply is the sphenopalatine artery right there, and that is the blood supply of this side. So there is a pedicle there. So once, what you do is actually when you start, you make this flap and then put it into the nasopharynx. And once you are done with all the drilling and the CSF leak and the tumor resection, you take this flap off from your nasopharynx and then just flip it right over up here. And then you have to make sure that the shiny side of the mucosa is up, and then you can seal this with either Tacile or any kind of fibrin glue. I usually put Tacile first. You can put a little bit of bone first here, whatever bone you have removed from the nasal septal bone. You can put it a bit of there over here, or I sometimes use the bone from the middle turbinate. The middle turbinate also gives you a good bone to put it up there. And then you put the flap on top of it, then put the Tacile, and then you can put Surgicel and some gel foam on top of it, and it will seal very nicely. You actually do not need any lumbar drains to go with it, because this flap, since it has a pedicle attached to it, vascularizes very quickly and seals the hole very nicely. I think it's quite commonly used these days. So this is the Hadad flap. Now, as I said, when you do the anterior skull base, you have to make sure what is your relationship is to the optic nerve. And again, this is actually animated pictures, so unfortunately,
Okay.
Can you see it?
Well,
you can't see now?
Yeah, we can't see the animation. Are they supposed to be animated now?
Yeah, you can't see it?
No, we can see it, but we can't see any animation.
Oh, okay, got it. I have to go back. Okay, so we won't be able to see it then. Okay.
Okay.
So basically what this picture is showing, that if you have an inferior medial tumor, yes, you can take it out via the endoscope, but if you have a superior lateral tumor, then you won't be able to take it out. Then you may have to do some other approach. You can do like a coronal blood flap, or you can do a supraorbital approach, or whichever approach you use to take it out. So this picture is just, it actually goes through several steps just to see which approach was taken, but unfortunately I don't think so I would be able to do it here. And again, this is again the same picture of this one taken out. And this was for the other one. Unfortunately, can't see the approaches. So the vital structures that are encountered when you do a transtuberculum, transplanum approaches are all these. And usually if you are a first-time endoscopic surgeon, then of course you cannot start with the anterior skull base approach. You have to start with the simpler sellar suprasellar approach, and once you are comfortable with it, then you can actually come into the anterior skull base. The most common one, of course, that's been used worldwide by many neurosurgeons, in fact I would say most now, is the Sellar and the suprasellar approaches. Again, anteriorly you have no limits, because you can take this part of the bone off. Laterally, again, the internal carotid artery becomes your it's a sort of a lateral extension, because sometimes you have natural fenestrations into the cavernous sinus, and so you can actually go in and take some of the tumor out from them. But if you don't, then of course you cannot take the extension that goes into the cavernous sinus, which it can be. I actually, if I cannot see a fenestration to the cavernous sinus and I feel I cannot take the part of the tumor off, then I usually leave the cavernous sinus tumor behind, and then usually use a cyber knife or some other method to take this completely make sure that the disease is gone. There are some surgeons who actually do skeletonize the internal carotid artery, and do take the tumor out from the cavernous sinus. I don't. Posteriorly, again, there's no limits as we'll go through it. So this is the transsellar approach, usually to the sellar, suprasellar, and partly the cavernous sinus. And again, as I said, laterally the carotids are your limitation. So here, if you see the anatomy, you can see the ICA and the sellar part. Now, as I said, there are surgeons who actually go drill the skeletonize this ICA and take quite an extension of the tumor out. I don't, but there are other surgeons who do that. And again, this is just some simple anatomy. The bony anatomy must be completely understood before undergoing these procedures, in which you have to understand where the optic nerves are, where the sella is, where the ICA is, and again you see the lateral the optic carotid recesses, which actually helps you to identify where the optic nerve and the ICAs are. So size is usually not a limitation. Of a larger tumor like that, it's all going into the sphenoid sinus. You can easily take it out, no problem. That's just a post-op scan. The bigger problem is actually the lateral extension, as I talked to you about. If you have lateral extension, as you can see over here, sometimes you are unable to, you can take the center part out, but sometimes laterally you can't. In that case, you can use either a subtemporal approach or any other approach to take it out. Meningiomas, yes, you can take pituitary tumors, yes, you can, all kind of pituitary non-functioning type of lesions or functioning can be taken out through this approach. Craniopharyngiomas, usually the initial craniopharyngiomas that are sellar and suprasellar extension are the best one to take it out. And as I said, if you have a redo craniopharyngioma, please do look at the anatomy. Even get a CT angiogram done, make sure there is bone there, the vessels are not exposed, the tumor is not adhered, if you are trying to do an endoscopic resection. Meningiomas, again, first time, it's not that difficult, you just need to know your anatomy. But if it is a redo, then again, you have to be very, very careful. And again, the craniopharyngiomas. Now, if you have this kind of tumor, the excess, now again, this is actually an animated picture that exactly just shows you that how to, now if this craniopharyngioma, as you can see that between the optic nerve and the pituitary gland, there is an access corridor, so it can be taken out. But for example, if this optic nerve is situated somewhere else, then probably this may not be a better approach, or the pituitary gland is completely up here, this tumor is completely suprasellar, not extending into the sella, then you would be damaging the pituitary gland, so then it would not be a good access. Then you may want to do a subfrontal or a terional approach to take the suprasellar component of the tumor out. Now again, this is an animation that actually just shows you, which I can't see over here. And just, you can use a subtemporal approach, as I told you. So the vital structures are the cavernous sinus is the most important one, with both ICH, which limits it laterally. Now again, in this case, so now for in my practice, since the sellar defect is not a big defect, and depends on whether you have a CSF leak or you don't have a CSF leak. If you don't have a CSF leak, which is generally the case in case you are doing a Sellar tumor, then you do not have to make a vascular septal flap or the Hadad flap that we talked about before. In this case, you can just simply use the mucosal free graft, which you can obtain from the middle turbinate. The middle turbinate is actually good. It gives you both bone as well as the mucosal free graft, and then you can just put the bone and the graft and then some fibrin glue to seal and Surgicel just to seal it up. People also use fascia lata to seal it up in countries where the artificial dura is, like in Pakistan, artificial dura is too expensive to use. I mean, it's cost almost as much as the entire surgical procedure. So we cannot afford to use artificial dura as the way I used to use in the US. So in this case, you know, people can use fascia lata, and again, I don't use fascia lata. I just use the middle turbinate graft. You can actually take both the middle turbinates off with impunity without any much issue, and that also gives you a lot of space, and your four-handed surgery can be done quite smoothly through that approach. So I just use that. So this is just a picture to sort of explain that. Okay, so again, very few limitations to the Sellar approach. You can do the intranasal is easy, the sphenoid sinus one is easy, the suprasellar extension is easy, cavernous sinus is partially easy. But if you have a middle cranial fossa extension or the lateral extension, then you won't be able to take it out through the endonasal approach. You can either leave the tumor behind and use a subtemporal approach or a terional approach to take it out, or you can, if it's not, if it's, or you can use cyber knife, either depending on the pathology. And relative contraindication, again, as I said, that if you had a previous surgery, please be careful while doing the redo. I mean, as far as redo pituitary is okay, but just redo any other kind of redos you have to be careful about. Next is the posterior cranial fossa. Now, posterior cranial fossa is probably the least that people do. In fact, in my practice, is also the very few indications to go to the posterior cranial fossa. So more indications are for the sella and the anterior lesion. Now, if you go to posteriorly, it's usually for if there is like if you're doing a biopsy or there is some extension of a chordoma or something like that, that you don't have to access it. You don't have to like open the dura to go on the other side. I mean, there are some neurosurgeons who actually does take the entire clivus out, does open the dura to access the midbrain, the brainstem through this area. I don't in my practice. It's only for me in case there is a clival chordoma which has an extension that I can take it out for a biopsy, or much more simpler cases that I do it for. This is now the transclival approach. Again, the most important thing is the carotids at this level is actually quite far apart. So, like, you know, in the cavernous sinus, as you know, that how the carotids are very laterally at the more posterior part of the sella, and then it sort of comes around at the more superior part. So the same way here, in the transclival approach, the carotids are actually quite laterally, so you don't have to worry about. Once you drill the bone, what will you will access the dura, and there's a lot of venous plexus around this area. So you may have some bleed from that. But again, in my practice, I only use this in case there is some sort of a clival lesion that I need to biopsy or a smaller lesion that I can access. This is just a little bit of the anatomy of this area. When you go through this area, I'm not going to go into detail of that. Everybody knows the anatomy. So this is one example of a petrous cholesterol granuloma that could be accessed through this area, but just for since it was a smaller lesion, it was easy. This was an extradural intradural chordoma. I only took the extradural part out of it through here. and the structures that are important is the basal and vertebral artery, but that comes after the dura. If you don't open the dura, if you just remove the bone to remove the extradural lesion, then you don't even have to access this area. But these are the vital structure around this area, and as I said, there are surgeons who would actually expose the entire clivus and would open the dura to reach the brainstem through these areas. Again, this is not my practice. So this is the conclusion that, again, a well-trained skull-based neurosurgeon needs to be familiar with both the transcranial and endonasal approaches, because endonasal does have limitation. As I said, that the midline lesions can be accessed, but anything that's lateral is not that easy to access, and that has to be done either transcranial approach or through radiation. And the best approach, you have to really tailor the approach according to the patient after carefully looking at the scans, and the best one is that avoids the neurovascular structure and gives you the best oncological, neurosurgical, and cosmetic results. Thank you so much.
Well, thank you very much, Aneela. And I tell you, I'm very glad that you came in at the last minute. I know you must be hungry for knowledge, and you must be hungry for new technology.
Yes.
And I love your attitude. I love your attitude of wanting to try things, which is the attitude that probably made you a really good neurosurgeon, I'm sure. And we're very lucky to have Victor here, because Victor is a skull-based neurosurgeon too. Victor, would you like to make any comments or questions to Aneela?
Yeah, I have some questions, especially in the parasellar and sellar region. Have you operated malignant tumors, like esthesioneuroblastomas? Because some small meningiomas could be operated, your technique, but some malignant tumors, what is the prognostic in this kind of tumors?
So I have not operated on any kind of neuroasthenioblastomas. I have operated on a couple of metastatic lesions that were actually in the sort of sellar, suprasellar area that could have been accessed through the endoscope. But as I said, I have not had the experience to do. The only malignant tumor I have done through the sellar is the metastatic lesion. Then I have also had a chance to do a glioblastoma that was actually accessing, it was in the third ventricle. I just recently did that in a 21-year-old girl. It was a GBM which was in the sellar and the suprasellar region, and I had to access it from the ventricle. So I actually access it from the top through the foramen of Monroe into the third ventricle. I partially resected the suprasellar component through that, and then I went endoscopically into the sellar area and removed the rest of it from that area. So these are my two experiences with the malignant lesions.
Could you please get off the screen share, Aneela, so we can talk to you? We're just looking at the screen.
Oh,
Yeah, just click on.
sorry.
Yeah, it's okay. Click on the green arrow and take it off it.
Okay.
Just click on that green arrow.
Okay.
On the there you go. Okay, there you go.
Okay.
Okay. Any more questions, Victor?
Yeah. Okay, Dr. Aneela, another question is, how many cerebrospinal fluids leakage have you had in this kind of procedures?
So with the vascular septal flap, since I have started like in my residency, we did not used to use the vascular septal flap. So when I was training during during my residency, but once when I did my fellowship, then I started to use that septal flap, the Hadad flap with the vascular pedicle, and that has significantly reduced the CSF leak. So, I mean, it is not more than 5 to 7%. I mean, it's rarely you would see CSF leak these days now with the septal flap. And you don't even need a lumbar drain. You don't even have to put a lumbar drain. Without the lumbar drain, just the septal flap, it works out fine.
Okay. Another question is, which has been the most difficult tumor, kind of tumor to operate by this kind of technique, by endoscopic technique, for you, for your experience?
So the Sellar, parasellar are great. Craniopharyngiomas, initial craniopharyngiomas are also very easy to take out. Meningiomas
Okay.
can be difficult because they are harder tumors, and for that you need so there's a specific kind of instrument that's out available which actually vibrates like a Pac-Man. And it vibrates. It's not CUSA. It is a different instrument, and if you have that, then actually taking meningiomas out is much more easier. It is, as I said, ultrasonic instrument, and it just cuts the tumor like that. It's like have you seen a mucosal debrider that an ENT person uses? Have you seen that? Do you know what a mucosal debrider is that an ENT surgeon uses? It is just a tinier version of a mucosal debrider, and for meningioma, since they are hard, that's easier to take out through that.
Okay.
Okay.
Okay. Congratulations for your successful procedures in this very difficult resection of tumors, because when we don't have that technology, we have to use a very wide procedures, very big procedures on the skull base. And if we have a good technology like you to use an endoscope, and also the experience is much better for the patient. Really, congratulations for your technique.
Thank you so much, Dr. Victor. Thank you so much.
Very good, Aneela. Well, I hope you become part of our team where you attend these regularly, and you're welcome. You're welcome to see the one. Victor did a great one this morning. He's a anatomist,
Uh-huh.
and he makes
I
some.
would love to. I would
Yeah,
love to see Victor's videos. Yes.
yeah, I'm going to show you Victor's video he made this morning. Just an awesome. I mean, the other neurosurgeons were awestruck. There was a wow because he had a live filling of the vessels and he was describing the anatomy as. How would you describe that, Victor, to Aneela? What you were doing this morning?
Well, excuse me again.
How would you describe the videos you were showing us this morning, Ipe and I, and Dr. Herrera? You don't remember those videos you were showing us this morning?
Okay. Do you have time in order to show you some video about this region?
Okay, well, sure. If Neil has a second, you have a second on Neil?
Yeah, I do.
Okay, yes, yes. I think she'd enjoy it.
Okay, only two minutes.
Yeah, sure.
Think 2 minutes.
Okay.
Okay.
There's a screen share now, Victor. Can you screen share or? Oh, there you go. There you go. You got it. You see that, Neela?
Yeah, I'm seeing it.
Okay. Could you show the one that was live
The,
where the vessels are filling?
the Willis circle. What we are seeing now is a supraclinal segment of both carotid arteries.
Uh-huh.
As you have said, Dr. Aneela, when we try to remove some tumors in the suprasellar region, we must know the arteries that are surrounded that kind of tumors. In here, I am explaining the arteries, the small arteries. This is the posterior communicating artery.
Mm-hmm.
Let me show you another video. I think is very important in order to see the anterior communicating arteries and also the arteries that are coming from the anterior communicating artery. This is the anterior cerebral artery, the other one, and this is the communicating anterior artery. The two segments of the anterior arteries, anterior cerebral arteries, and this is the A1 segment of the anterior cerebral arteries, and okay, okay, much better in this. I am going to displace the frontal lobe, and you are seeing in this of Hübner, recurrent artery of Hübner, and the arrow in here is showing the small arteries that are coming from the anterior communicating artery. Here, in this side, is the origin of the recurrent artery of Hübner. This, and the small arteries that are coming from this segment of this artery. I have almost 100 brains injected with silicone in order to see these arteries and its branches and their branches.
Wow, it's fantastic work, Victor.
Excuse me?
Fantastic work.
Well, I'm gonna send you his video, Aneela, that he made this
Okay.
morning. It's a long. You'll be. I think if you love it, most neurosurgeons I've met love anatomy.
Yeah.
So I'm sure you're one of them, and I'm
Yeah.
sure you'll love his video. And Victor's going to be a part of this whole channel. So
Great.
okay, Aneela, I'll let you go. I know this is probably your day off. I really appreciate you coming by and your time off to
No
help.
worries. I enjoyed it. Thank you very much for inviting me. I really enjoyed doing it.
Well, I
Look,
hope you have
look,
hangouts like that to educate the world, not just a few people. Once we get going, I hope we get a pretty big audience worldwide,
look,
not just in Pakistan, but in the world.
Dr. John,
Yes.
Dr. Aneela,
Yes.
look at this picture.
Okay.
In here we are seeing the optic nerves, this and the other one, the optic chiasma and the carotid supraclinode, and this is really nice because in here we can see with a very specific detail the small branches of these arteries.
That's important to know.
I hope to, yeah, I hope to participate in the next courses with John Bennett in order to show you this kind of work.
Yeah, our next conference, Aneela, is skull-based surgery. Probably
Okay.
in a couple of weeks, and you're welcome to present if you'd like to present at the skull-based surgery.
Sure. Great. Yeah, I would love to.
Great. Okay, Victor.
Okay.
Thank you
Yeah.
both very much.
Thank you.
Okay, good night.
Good night.
Bye bye.